So, thank you to the chairpersons. I'm showing you how to manage a subluxated case. Basically, in this one case, almost all the things that you would do in a subluxated patient, cataract patient. Now, this is fashioning the reverse scleral flap, or the what's it called? Hoffman pocket. Yes, forgot. So fashion the Hoffman pocket in a before you make your incisions, so that your eyeball is rigid. Stain with trypan blue, 2.2 or 2.8 millimeter incision. So this, in this patient, the as you can see, the area of zonal adhesions was pretty large, and after initiating the rhexis, it was difficult to do the rhexis because the lens was moving around here and there. So in my left hand, I'm using a capsule grasper just to grasp the capsule so that the lens is stable, and then fashion the rhexis. The most important step in a subluxated cataract or a subluxated lens is being able to do a rhexis. If you're not able to do a rhexis, you have to resort to lensectomy, vitrectomy. So the first challenge has been overcome, and then using this railroad technique, Prolene suture, 10-0 Prolene suture, on which I have loaded a Ahmed segment. So 2 millimeter away from the limbus, in the area of the Hoffman pocket, the needle is exteriorized. Both the needles are exteriorized using a bent 26 gauge needle. So one has to be careful in this particular step so that you don't hit the lens. And then implant this CT segment. Generally, it doesn't go through a 2.2 millimeter incision, and you have to enlarge to a 2.8. And then guide this segment into the bag. Then using the capsule hooks, you have to stabilize the capsular bag. So right now, I'm not going to fix the CT segment. It is just guided into the bag. You can see it is here in the bag. And then using these 4 capsule hooks for support. And this is a pretty hard cataract. So hydrodissection and then direct chop. This is pretty routine. The only thing is that you have to be careful in the lateral separation of the nucleus. You shouldn't separate it too much. Otherwise, you will cause greater stress on whatever zonules are left behind. And slow and steady wins the race. And here you have to be slow. You cannot be as fast as you would in your normal cataract surgeries. So remove the last bit slowly. Then the epinucleus removal and placing the single piece intraocular lens into the bag. Remove the cortex. And then, as I noted that there was slight decentration of the intraocular lens, I went ahead and placed the CTR through the side port. There you go. And of course, the MS segment was sutured in the scleral pocket. Thank you. If you have any questions.
We should ask Pallavi if she has any questions. Do you have any questions?
Okay. I think he has stopped before time, so we have time for 1 or 2 questions.
Just wanted to point Shalabh, wonderful management indeed. May I know what is the reason of subluxation in this?
Trauma.
So yeah, so you can do all that juggling in a post-traumatic subluxation because expectedly one segment of the lens is dialyzed, but the other segments are stable.
Yes, healthy and stable.
It's a progressive dialysis, then possibly all these maneuvers are going to dialyze it more and sink it more. So there are 2 steps which I would like to do differently. I mean, wonderful management, and the order was absolutely spectacular. But before staining or painting the anterior capsule, I would always plug the dialyzed portion with dispersive viscoelastic because very commonly these dyes go under
Yes.
surface and then mar the red glow for the subsequent steps.
Yes, very true. It has happened just day before yesterday.
Yes, it does happen at times. So it's a good idea to plug that portion so that the dye does not leak into the posterior surface. The other thing is before implanting any ring, particularly the CTR, I always remove or loosen out the capsular hooks. In fact, disengage them completely because if they are tented, there is a tangential pressure in that particular segment, and when you are rotating the CTR, the eyelet goes and hits that area or rotates through that area which is tangentially pressurized already with the help of capsular hooks because you're supporting the equator vertically.
Yes.
So it just might rupture that area. So I always tend to disengage them, put in the CTR. If I'm doing it midway in the surgery, then I put the capsular hooks back. If I've completed the nucleus management, then I completely remove it and then proceed with the CTR placement and then.
Yeah, so as you saw, I had removed 3 of them, just left 1 before placing the CTR because I agree with that point. You don't want to tent the capsule at the equator.
And the third and final concluding point is I'm not a very big proponent of the offense pocket anymore because in some cases it actually causes a very disturbing bleeding. And if in the process of making that
initial, yes, it bleeds in the initial part.
if you have incised the conjunctival insertion somehow and it bleeds from that point, then it causes a ballooning of the conjunctiva. Of course, it can be managed by doing a peritomy and then cauterizing and doing a spherical flap on the other side. But yeah, I mean, maybe it takes a few seconds extra, but I still prefer to do a peritomy nowadays and not really rely on the
Hoffman pocket.
punch,
Yeah, so I mean there are various ways to skin the cat, and it depends on your preference and technique and what you believe works in your hands. So yeah.
That was a nice discussion by 2 experts.